Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kaladze has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
Well, welcome back, folks. We haven't been here for a while. Dr. Paul's been out skiing and having all kinds of fun stuff. Isn't that right, Dr. Paul?
I had fun, Terry. Yes.
You had fun. You're allowed to have fun once a year. We're now in the middle of April, right? And there's a lot of stuff going on with GLP-1 medicines that we're going to talk about on this podcast. So if you're interested in learning more about GLP-1s and all the things that might affect weight loss and that kind of stuff, we're going to be talking about that. But before we get started, we do want to thank our sponsors. We want to thank our sponsor, which is the MetabolicMDs.com. They specialize in helping folks with weight loss, tackling all kinds of topics around metabolic health. You can visit them at MetabolicMDS.com. We also want to thank our sponsor, CGMDoctor.com. For me, I use a CGM all the time because I'm a diabetic, but CGMs are becoming very popular for folks wanting to lose weight and to understand how their metabolic systems are working. And using a CGM is a great way to tell that. So you can get a CGM directly from CGMDoctors.com. Is that correct, Dr. Paul?
CGM-doctor.com.
You're right. We forgot the dash. So there is a dash in CGM-doctor.com. All right. So now that we have that out of the way, so if those folks listening, hopefully they'll go to those websites and check them out. Let's get into the topic of the day, which is GLP-1s and all the changes that are going on for those kind of weight loss medicines. Give me an update.
So these medications, of course, have revolutionized weight loss over the course of the last few years.
Yep.
Two brand name pharmaceutical companies in particular, Novo Nordisk and Eli Lilly, invested to develop these GLP-1 medications, and
right.
Those then came out as Wegovy and Zepbound for weight loss. They had a similar formula that was used for diabetics, different brand names, but the medications for weight loss are Wegovy and Zepbound. Now,
I see the commercials all the time, by the way.
Yeah, now they're out there all the time.
Yeah.
Now, these medicines became so popular that there was a shortage of these medications for a period of time.
How long was that back? Like last year?
Oh, over the last year and a half or so.
Okay.
Just ended here in the last few months.
So if you wanted the medicines, you had a hard time getting them because they were short.
Yes, some and it was variable. Sometimes it was only certain doses that were not available, etc. But the FDA is the arbiter of that, determining if there's a shortage. And the reason that's important is because if there's a shortage of medication, then the FDA allows compounding pharmacies to go ahead and make versions of these medications. And of course, that's been all the craze lately in terms of compounded medications of these types being provided to individuals through providers that work with compounding pharmacies.
So how many compounding pharmacies do you think were out there? Just take a wild guess.
Oh, I think hundreds. Yeah.
And so a lot of these places were prescribing compounded medicines versus the
right.
Brand name.
And they were allowed to do that because there was a shortage.
Right.
And when you think the word compounded, you kind of think of something put together. So they would mix the weight loss component of these medications with, for example, vitamin B6, which can decrease nausea.
Right.
Or glycine, which is an amino acid which can help maybe prevent muscle wasting. So the FDA, over the last 6 months, and then specifically for one of the medications in the last 6 weeks or so, has said the shortage is over. And so generally that would mean the compounding pharmacies are precluded then from making these medications, which, I think there are millions of people on compounded GLP-1 medications.
So you're talking about because there's no shortage, the FDA is saying you got to stop making compounded medicines because you can get the real deal.
Right, exactly.
Okay.
Yeah. And the brand name medication or pharmaceutical firms have said, there's some impurities in those compounded medications. They could potentially
Sure.
be dangerous. So there are some risks associated with those.
Now, you used them for a while, right? That's what.
Yeah, previously.
Previous to
Yeah.
this, but now you're
Yeah.
kind of going down the brand name route.
Yeah, well, so what's going on now? And there's a lot of confusion right now. But what happens is the FDA says you can no longer make these routinely available to patients, compounding pharmacies. And of course, the lawsuits are flying back and forth, between the Compounding Association, the Association of Compounding Pharmacies, the trade group that is suing the FDA, and the brand name drug companies are looking at legal action against not only the compounding pharmacies but the providers
Sure.
that are prescribing these medications.
And that's the last thing as a service provider you want to be involved with is some type of litigation that could just
Well, yeah, and the concern then is the supply of the medication you provide patients going to be abruptly cut off,
Right.
And are they going to be left holding the bag?
How long do they give you? Do they give you notice of?
Yeah, there was notice. I at least a couple months notice. I
Okay, so
think. Yeah.
if a provider's providing somebody a compounded medicine, then they've got to notify their patients that this is going to go away.
Yeah.
And they got to switch them over to a brand name.
And for the limited number of patients we've had on compounded medications, we let them know that right from the beginning. But that trip is pretty much over now because beginning here in April, providers are going to be prohibited from providing these compounded medications and, at risk for legal action and that type of thing. So we're 100% making that transition as well. Now, I got to tell you, some of the compounding pharmacies, some of them very vehemently are disputing this. And I think going to battle some of the lawsuits that are going to be taking place. Their argument is that what the service that compounding pharmacies and compounded medicines provide is that it's customized medicine, and that is actually true in a number of areas. For example, there's some medications that are oral medications that, compounding pharmacies can compound into what's called a sublingual medication that goes under the tongue. So the compounding pharmacies can at times offer formulations that the brand name companies can't provide, but those are supposed to be provided by the compounding pharmacies on a customized basis, as in an individual patient has an individual need that allows them that it makes sense for them to have a specialized medicine. But that's not what's been going on with these compounded weight loss medications. It's really just they're just kind of been mass produced and distributed as compounded medicines.
So one thing I'm getting confused about, does insurance cover any of this?
Insurance generally does not cover compounded
If you're diabetic,
medications.
you can get the other brand names, but as a weight loss, somebody who's wanting to lose weight, that doesn't cover that.
Well, let's back up here. Yes, okay. If you're regarding GLP-1s, if you're diabetic, generally you have access to Ozempic or Mounjaro, is the brand name of the medications. There is insurance coverage in some insurance plans for the obesity formulations, which are Zepbound and then Wegovy. But that insurance still is somewhat limited because of the cost of these medications.
Right. And how much, just roughly, you don't have to know the exact number, but what does it cost a general person like me if I want to go on one of those medicines?
If you don't have insurance for it?
Yeah.
So previously it was in the $1,000 range on a monthly basis.
1,000, and
Yeah,
you get
but
one shot a month? Is it one shot a week?
it's one shot a week.
Okay.
But the cost would be around $1,000 a month.
Okay.
But both the brand name companies have created discount programs for these medications.
And how much discount am I getting?
It's cut in half. Yeah.
So $1,000 is $500.
Yeah, sometimes even a little bit less, depending upon the brand you pick and the extent of the dose, the concentration.
Okay.
So it's come way, way down, and that's another reason we're making this transition, because it is more accessible to people. Getting into the range of what the compounded medications we're going for. So. It's a very volatile landscape out there. And so we've made the decision in our practice that we're going to make patients, we've always provided brand name medications to patients with insurance or some without insurance that wanted the brand name medication. But now we're going to be exclusively providing the brand name medication for patients, which kind of leads us into the topic we were going to talk about today in terms of what kind of provider should people seek out to help guide them related to these medications?
Yeah, so let me give you an example. I went to my doctor, and I like my doctor. He's a great guy, but I get in to see him. 20 minutes later, I'm walking out the door. He's not spending a lot of time with me. I'd be afraid if I was going on these medicines and the possible impacts that if I don't have somebody overseeing that a little bit more carefully, I could get into trouble. And that's kind of what you in your practice, you're not only providing the medicines, you're providing the guidance that they need to make sure they're using them correctly and getting the best out of this process.
Right, and using it most efficiently. Because here we were taught, for two reasons: to avoid dependency, and also to help keep the costs down and the time period of treatment down. Because that really is the most prudent way to utilize these medications.
Period of treatment, that's something I don't think a generic doctor or general practitioner, they're not going to be checking in with you like you kind of check in with your patients. How you doing? Are you losing weight? It's like a whole different world, isn't it? Where it's like they give you the medicine, you go off, and if you got a question, call them. Whereas you're more integrated into their routine.
Right. I mean, again, I got a lot of friends that are primary care doctors, and we're close, and they've got, unfortunately, they've got a tough job. Mostly it's disease management, which is, let's just look at, when you see them once every 6 months, let's look at the medicines you're on. Can the dose go up or down? Do we need to add a new medicine related to your hypertension or prediabetes or diabetes or whatever?
Right.
And so, management of a GLP-1 for weight loss for those docs it's just an add-on. It's another thing I need to get done in a minute and a half during the appointment. And so that's an entirely different approach than I take, because, my focus has always been metabolic health, disease reversal in association with weight loss, reverse your prediabetes, lose weight so that your hypertension resolves, etc. So, I think there's something to be said for specialization in this area.
So walk me through, you're only allowed to practice in 4 states, which is Indiana, Arizona, Florida, and Ohio.
Correct.
I got those right.
You got it right, Terry.
So I'm a patient. I'm coming into you for the first time. What are you going to and I want to use these medicines. What are you going to do? Are you going to just put me on them right away? Are you going to ask questions? Are you going to do tests? What are you going to do?
Yeah. So first of all, fortunately, we see nearly all our patients by telemedicine now. So It's very convenient. They can be at home in those states. I actually have patients that make sure they're in one of those states. The medical board rules are the patient has to be in that state while you're providing medical care. So I have patients that drive from Chicago into Indiana and California.
They make the call.
Yeah, I mean, it's actually gratifying, because I have people that fly into airports. We do their visit while they're in an airport, and then they fly back out. So they're in a state that I'm licensed in. So we're making sure we're adhering to those medical board rules.
Oh yeah, you have to.
Yeah. So the first visit is an intake. Actually, even before the visit, for people that make inquiries to the practice and are serious about wanting services, I'll do a 15 or 20 minute complimentary phone consultation
So
with people.
you're going to talk to them. You're not going to charge them. You just want to learn about them.
Yeah. What's
They
your
wanna learn about you.
situation? Is this a good fit? Good fit for me? Are you
Right.
serious about this? Because if you just want medicine, I'm not your guy.
So you're not the guy just to prescribe something.
Yeah.
And-
So
yeah.
So we have that discussion. Again, being careful not to have any issues with the medical board requirements. So it's a very general upfront discussion. But then people schedule with me, and we schedule the first visit for an hour.
Yeah.
And we do a detailed medical intake, and then we look at labs.
So you have to get a lab work. So if somebody's signing up, you're going to say, make sure you got your lab work done, or you're going to send them to some place? What do you
Yeah,
want to do?
if they've had recent lab work, we can look at that.
Okay.
But otherwise, it's pretty simple. We just send a lab order to the patient. They can go to their local lab and get it, and then upload into our medical record portal their lab information.
Okay.
So we have that initial visit. I like to include CGMs as part of that process, so people get a good handle on their blood glucose physiology. 60% of Americans are overweight, about 50%, mind-blowing number, about 50% are either pre-diabetic or diabetic. 15% of American adults are diabetic, and nearly 30 to 32% are pre-diabetic. Half the pre-diabetics don't know they're pre-diabetic.
Right.
So we like to slap a CGM on, a continuous glucose monitor on them for a couple weeks, because then they can see what's going on with their blood glucose physiology. And, blood glucose, problems with high blood glucose is the reason the majority of Americans are overweight. And, we've talked repeatedly about, the high carb intake, going back to the food pyramid, and that's resulted in high blood sugar. High blood sugar gets converted to fat in the liver. So high blood sugar and increased carb intake is the reason for the majority of diabetes and obesity in the country. So I like people to get a look at that, because you know how it is with those CGM curves.
Oh, yeah.
The way my patients have put it is, once I see it, I can't unsee it. Once they get that baseline knowledge, that foundational knowledge as to why they might have had health problems or why they're overweight, and they see the data, it can be life changing.
Oh, let me tell you a quick story on that. Right, I got a CGM, started using it years ago. Several years ago. Went to McDonald's for a small fry, Diet Coke, small fry. That was it. Small fry, Diet Coke. Didn't think it would impact me that much.
Because it was a small fry?
Because it was a small fry.
Yeah.
Huge spike.
Yeah.
I couldn't believe it.
Yeah.
And until you see that, you don't quite get it.
And you can't unsee it, right?
You can't unsee it. So now I split a fry with somebody I may eat 4, right? 4 or 5, and I'll eat them really slow. But
yeah.
Yeah.
Well, I have a lot of patients that come to me that their primary focus is weight loss. But then after they see the CGM data for a couple weeks, then they realize the issues are much bigger. And then we couple the CGM use with something that I think is more important than a cholesterol level, which very, very few people get, which is a fasting insulin level. So, in this blood glucose physiology, excess weight, pre-diabetes issues mixed up is the problem called insulin resistance. And we'll drill right down to a level of insulin resistance by getting a fasting insulin level. So, you may go to your doctor and you get a cholesterol level twice a year, but I've only had a handful of patients come to my practice over the last 7 years with already have had a fasting insulin level. And for the majority of those patients that are overweight or pre-diabetic or have diabetes in their family, the fasting insulin level is more important than the cholesterol level.
All right, so I'm on the phone with you. You're talking to me. You're looking at my blood work. This is episode number 1 or visit number 1.
Well, so the intake is first.
Yeah.
Then you got the CGM on for a couple weeks. We make sure we gather all the lab work we need during that period of time. And then we have another hour visit.
So it's an hour in front, hour after the CGM.
Yeah.
2 weeks later.
Yeah, usually 2 weeks later.
Okay.
Yeah.
And what do you find in most of the cases?
Well, in most of the cases, patients have some insulin resistance.
Yeah.
It's variable. It can vary from just a bit of insulin resistance to, bad insulin resistance. And you will see that both in the insulin numbers, the insulin resistance calculation called the HOMA-IR, HOMA-IR, if people want to look that up, and then in the CGM data. And based on that, then we put a plan together. And if people are focused on medicine, and I realize the genie's out of the bottle, people are going to want medicine. Then we talk about how do we integrate a comprehensive plan using this data into your brand name now, GLP-1 use,
Right.
with a long-term focus. And I believe that this is the appropriate way to use these medicines in a long-term focus of using the medicines to get a restart, but not create, hopefully, lifelong dependency on the medications.
So if I'm coming to you thinking I'm going to get on this GLP-1 medicine, it's going to be at least a 2-week period until you understand everything about me before you let me have that medicine.
Yeah.
Which is the right thing to do.
Yeah, we can shorten it a little bit, but in general, that's the approach we take. And then we talk about, the 3 pillars of the programs that I've managed for years, which is, what's your carb intake going to be?
Yeah.
Let's make sure you're getting protein, because on these medicines, you're going to have some muscle wasting. So we have to talk about you getting adequate protein.
You mean you're going to reduce your muscle mass?
Yeah.
Muscle wasting.
Yeah.
Okay.
Yeah. I mean, we all do as we get older, Terry.
Oh, I haven't. I look as good as I did when I was 21.
You do. You look great, Terry. You look great today. I forgot to mention how good you look today.
Well,
okay.
thanks.
All right. So you're going to have muscle wasting. You got to get adequate protein, which can be a challenge on these medications because you're getting hunger suppression.
Oh, yeah.
So decreased carbs, increased protein. We don't focus that much on fat unless people really have a significant cholesterol problem. This is another nuance of what we do. If lower carb diets are higher in fat. So if you've got a borderline cholesterol, rather than knee jerk, you need to be on a statin. Maybe let's look at, a detailed review of what your cholesterol subfractions are to see if that really is needed for you. Because people can have high cholesterol and have harmful subfractions of LDL, the different types of cholesterol, which can be damaging. But you could have a high cholesterol and have really the benign type of LDL subfractions where it's not a big deal. And the reason this is a discussion is because low-carb diets can be higher in fat. But generally what I say to patients is let's keep your carbs low, your protein high, unless you have an obvious cholesterol problem. Let's not worry about the fat. We'll get into talking about good fats and bad fats over time. If you have high triglycerides, another kind of fat in your blood, low-carb diet is the way to go, because low-carb diets decrease triglycerides. Not intuitive, but triglycerides, that fat in your blood, are formed from the conversion of blood glucose to fat in the liver. You decrease your blood glucose levels, you're going to decrease your triglycerides. And I see that over and over again with my patients.
So the other thing I think you talked about before is you never start anybody out at maximum dose. You're starting them at a minimum dose.
Yeah.
And working her up if they need to be worked up.
Yeah, that's actually the way the medicine should be prescribed. Is you start a lower dose. Let me throw in one more thing. There's the dietary component. We like to look at a little bit of intermittent fasting. We're talking about 14 hours or 16 hours overnight, not days of fasting. And then the strength training component. And of course, I have the health coaches that work with my patients related to all of this to provide, detailed ongoing guidance. Then you get to the medications. And again, we're going to be prescribing only brand name medications. So our goal here, you've heard the term I used before, I call it microdosing, and that is keeping the doses low and hopefully for limited periods of time, using this medication in a period measured in months, not years.
To kind of reset your health.
To reset your health. And, quite honestly, the two situations where I start patients with the medication is when they want to get going early on and they meet criteria. But the other is when we've done a program for a while with the intermittent fasting, strength training, low carb, but they hit a little bit of a stall if they want to goose this along a little bit.
Yeah.
Again, low doses, limited periods of time, try and titrate up, not to a very high level, and then titrate back down. And also I'm going to mention as you're titrating back down, getting a CGM back on to help guide your diet while you're titrating down and off the medicine can also be exceptionally helpful.
So CGMs are relatively, I mean, for somebody who's not a diabetic, the ones that are offered through cgm-doctor.com, they're like $99 a month for
They last 2 weeks.
They last 2
yeah.
weeks. So it's basically $99 a month.
Yeah.
The things you'll learn with that CGM will blow your mind.
Yeah.
It really will.
Well, you've used one for how many years?
Probably 4 or 5 now, and they're just absolutely life-changing.
Yeah. Well, and you're diabetic and you knew you had a problem. Think
Yeah.
about all the people that I see that get a CGM on, were not aware they had an issue and become enlightened by that.
So I'm worried that some people would be scared of that, scared of knowing.
Well, you know, it's the men. You know,
It's the
the
men.
men don't want to know.
Yeah, that's
the
true.
women are a little bit more insightful. They understand that life is maybe a little bit more vulnerable. Us men would rather just not deal with it. So.
All right, so as we wrap this podcast up, the thing I want to remind folks is if you're in the states that Dr. Paul practices in, which is Arizona, Florida, Ohio, and Indiana, he can help you with your metabolic health.
Yeah.
And help you get on the right track to lose weight. The other thing that you're involved with is through cgmdoctor.com, which is a website where you offer CGMs at a really low price, actually the lowest price available.
And the reason we created that site is because I can't provide medical care to patients I'm not licensed in, but you can get a CGM. We
Anywhere.
have all kinds of, information on the website. So you generally then can utilize, your CGM effectively. I do want to go back and mention one thing is we're drawing this contrast between, people going to their doctor and their doctor maybe not being an expert in this area, not having time to deal with it. I do think there is an advantage of working with somebody that this is their, like me. This is their life. This is what they do.
Right.
And you look at the, there are relative costs to each of those. You go to your doctor and they might not know how to get you the discounted rate for the medication, that we talked about early on. And my staff has become experts in that to make sure you're getting the lowest rate for the brand, the lowest cost for the brand name medication. And then the other component of that is, if copays or straight out of pocket are an issue, the goal here is to, let's limit the time that you're going to be on this medication. So let's use a focus approach so you can be on this medication for, less than a year as opposed to get into a routine because you aren't doing the other things. You don't have the guidance that we talked about and you're on for a number of years. So we can help people manage those costs with a prudent approach there.
All right. Well, hey, this has been a fun podcast. I learned a lot during this one.
And if you go to CGM Doctor, you will also see that the Bible on CGM use, the Bible on CGM use, which is the Continuous Glucose Monitor Revolution for Non-Diabetics, is shown there.
Written by who?
Some Kolodzik guy. I don't know. But that's the best-selling CGM book on Amazon. We're getting a lot of momentum with that. But it's really a step-by-step guide as to how to use your CGM effectively, either independent of a GLP-1 or with a GLP-1.
And the cgm-doctor.com has tons of videos that gets into details about all these kind of things. So even if you're just curious, go out there and take a look.
Yeah, and who took those videos, Terry?
I produce those videos. They're fine videos. All right, so folks, this has been it for the Metabolic MD with Dr. Paul Kolodzik. We want to thank our sponsors, metabolicmds.com and cgm-doctor.com. Thanks, Dr. Paul.
All right, thanks, Terry.